Hi everyone, it's Veronica. So today I'm going to be presenting about the image evaluation criteria for the routine X-ray exam of the knee. So starting off with the anatomy, I have three images here that demonstrate the anatomy of the knee very well. Image number one is a lateral image of the knee. So we have the distal femur with the popliteal surface, the proximal tibia and fibula, and the patella and lateral profile with the patellar surface right here. The second image is a close-up of the femur, so we have the medial epicondyle and condyle, the lateral epicondyle and condyle, and the intercondylar fossa in between those. And then in between the femur and the patella, we have the patellofemoral joint right here. Then the third image is kind of an overall image of an AP knee, so we have the proximal tibia and fibula, the distal femur once again, and the patella. For the tibia, we have the medial condyle, the lateral condyle, the intercondylar eminence in the middle, and the articular facets of the tibia on each side. For the fibula, we have the fibular head and neck. For the distal femur, once again, we have the medial epicondyle and condyle, the lateral epicondyle and condyle, and the intercondylar fossa right here. And then for the patella, we have the base at the top and the apex at the bottom. So I have three learning objectives for my presentation. So first, we're going to differentiate each position of the knee out of the four during a routine exam based on the position of the anatomy demonstrated. Next, we're going to determine the proper amount of part obliquity for both internal and external rotations of the knee based on superimposition of the tibia and fibula and based on superimposition of the femur and the patella. And then lastly, we're going to identify the presence of over or under rotation of a lateral knee projection based on the superimposition of the posterior borders of those femoral condyles. So here I have the exam routines listed for both Bontrager and Beaumont. So for Bontrager, we're going to do an AP knee, an internal oblique knee, an external oblique knee, and a lateral knee. For Beaumont, if the patient is under or over the year of 5, we're going to do an AP knee, both obliques, and a lateral once again. And for Ricketts, we do AP bilateral knees and PA hands and wrists. So here is the patient history. This patient was an outpatient and they had come in complaining of pain in the left knee. Signs and symptoms included posterior leg swelling on the left side along with that left knee pain. 4 views of the knees were obtained and 2 views of the patella were obtained to determine if osteoarthritic changes were present in that left knee. So now moving on to the evaluation criteria, we're going to start with the AP knee anatomy demonstrated, and then here's a reference image of what an AP knee should look like. So the first criteria is distal femur and proximal tibia and fibula are shown. I did say met for this one because you can see the distal femur here in profile and the proximal tibia and fibula. The second criteria is femorotibial joint space should be open with the articular facets of the tibia seen on end with only minimal surface area visualized. Once again, I said met for this one because that femorotibial joint space does appear open, and you can only see a little bit of those articular facets of the tibia on each side. Now we have position, so the first criteria is no rotation as evidenced by symmetric appearance of femoral and tibial condyles and the joint space. I did say met for this one because the joint space does appear pretty symmetric, and those condyles of the femur and tibia are right on top of each other and symmetric as well. The next criteria is the approximate medial half of the fibular head should be superimposed by the tibia. I said met for this one because you can see here the medial part of that fibular head is superimposed by the tibia here. The next criteria is the intercondylar eminence is seen in the center of the intercondylar fossa. Once again, I did say met for this one because you can see that intercondylar eminence of the tibia right here, and it is directly under that intercondylar fossa of the femur. And then next we have center of collimation field should be to the mid-knee joint space. So I did say not met for this one. It appears that this image is centered a little bit too high and a little bit too much to the left here. Next we have exposure. So the first criteria is optimal exposure visualizes the outline of the patella through the distal femur and the fibular head and neck do not appear superimposed. So I did say not met for this one, although you can see the outlined patella really well through the distal femur. That fibular head and neck is superimposed a good amount. If you look at the reference image here, there's only a little bit of superimposition going on and a lot of space in between that tibia and fibula, but on this image, there's not as much space and there's more superimposition, which means that a little bit of rotation may have been the case here. The next criteria is no motion should occur, trabecular markings of all bones should be visible and appear sharp. I did say met for this one because the bones do appear clear and sharp, and no motion is evident in this image. Next, we have soft tissue details should be visible. Once again, I said met for this one because you can see that soft tissue here and here. So moving on to the internal oblique knee, anatomy demonstrated. The first criteria is distal femur and proximal tibia and fibula with patella superimposing the medial femoral condyle are shown. I did say met for this one because you can see the distal femur here and proximal tibia and fibula, and that patella is superimposing the medial femoral condyle right here. The next criteria is lateral condyles of the femur and tibia are well demonstrated and the medial and lateral knee joint spaces appear unequal. I also said met for this one because you can see here those lateral condyles of the femur and the tibia are well demonstrated and in profile. And the joint spaces do appear a little bit unequal. The joint space appears more open on the lateral side here in comparison to this medial side here. Next, we have position. So the first criteria is the proper amount of part obliquity demonstrates the proximal tibio-fibular articulation open with the lateral condyles of the femur and tibia seen in profile. So I did say not met for this one, although the lateral condyles of the femur and tibia are seen in profile. That proximal tibio-fibular articulation doesn't appear as open as it should be. If you look at the reference image right here, you can see that there's less superimposition and that articulation is very open. In comparison to this image, it's less open, which means we could have obliqued the patient a little bit more to open up this articulation right here. The next criteria is the head and neck of the fibula are visualized without superimposition and approximately half of the patella should be seen free of superimposition of the femur. The center of the collimated field is to the femorotibial joint space. Once again, I said not met for this one because if you look at that patella, half of the patella is not seen free of superimposition. In fact, that whole patella is superimposed by that femoral condyle, which means that we could have obliqued the patient a little bit more so that we could see more of that patella here. And the centering of this image is also a little bit off. We are centered a little bit too high since that joint space is down here. Next we have exposure. So the first criteria is optimal exposure with no motion should visualize soft tissue in the knee joint area, and trabecular markings of all bones should appear clear and sharp. I did say met for this one because the bones do appear clear and sharp, and no soft tissue is visualized in that joint space. And then the next criteria is head and neck area of the fibula should not appear overexposed. I also said met for this one because if you look at that area here of the fibula, it does not appear overexposed. So moving on to the external oblique knee, anatomy demonstrated. The first criteria is distal femur and proximal tibia and fibula with patella superimposing the lateral femoral condyle are shown. I did say met for this one because you can see the distal femur in profile and the proximal tibia and fibula, and that patella is superimposing the lateral femoral condyle right here. The next criteria is medial condyles of the femur and tibia are demonstrated in profile. So I also said met for this one because that femoral condyle and the tibial condyle is in profile right here. Next we have position. So the first criteria is the proper amount of part obliquity demonstrates the proximal fibula superimposed by the proximal tibia, the medial condyles of the femur, and the tibia seen in profile. So I did say met for this one because you can see that the proximal fibula is completely superimposed by that tibia, and the medial condyles of the femur and tibia once again are seen in profile. The next criteria is approximately half of the patella should be seen free of superimposition by the femur. So I did say not met for this one because if you look at the patella right here, half of it is not seen free of superimposition, only a part of it is, which means that we could have obliqued the patient a little bit more so that we could see more of that patella on the lateral side here. The next criteria is femorotibial joint space is the center of the collimated field. Once again, I said not met for this one because we are centered a little bit too high here, since that joint space is down here. Now we have exposure. So the first criteria is optimal exposure should not visualize soft tissue in the knee joint area, and trabecular markings of all bones should appear clear and sharp, indicating no motion. So I did say met for this one because the bones do appear clear and sharp, and no soft tissue can be visualized in that joint space area. And the next criteria is technique should be sufficient to demonstrate the head and neck area of the fibula through the superimposed tibia. Once again, I said met because you can visualize that fibula really well through that tibia. Lastly, we have the lateral knee anatomy demonstrated. So the first criteria is distal femur, proximal tibia, and fibula and patella are shown in lateral profile. When you look at the image, you can see that all of those structures are in lateral profile. The next criteria is patellofemoral and knee joints should be open. So I did say not met for this one, although the knee joint does appear pretty open here. When you look at that patellofemoral joint space, it does not appear open. If you look at the reference image here, it appears way more open than the image here, which means that there might have been under or over rotation present in this case. So now we have position. The first criteria is over rotation or under rotation can be determined by identifying the adductor tubercle on the medial condyle if visible, and by the amount of superimposition of the fibular head by the tibia. So I did say not met for this one. It appears that there is over rotation present in this image since there is less superimposition of that fibular head right here. If you look at the reference image, that whole fibular head is superimposed, and here it's not as much, which means that there is over rotation. The next criteria is true lateral position of knee without rotation demonstrates posterior borders of femoral condyles directly superimposed. So I also said not met for this one because if you look at those posterior borders of the condyles, they are not directly on top of each other and directly superimposed, which means there was rotation. The next criteria is patella should be seen in profile with patellofemoral joint space open. I did say not met for this one because that patellofemoral joint space does not appear as open as it should be as a result of that over rotation. And then the next criteria is the 5 to 10 degrees valid angle of the CR should result in direct superimposition of the distal borders of the condyles. I did say met for this one because if you look at the distal borders right here, they are directly on top of each other. The next criteria is the knee joint is in the center of the collimated field, and I said not met for this one because once again we are centered a little bit too high right here since that joint space is down here. And then lastly for lateral knee we have exposure, which has one criteria, which is optimal exposure with no motion, visualized important soft tissue detail, including fat pad region anterior to the knee joint and sharp trabecular markings. So I did say met for this one because the bones do appear clear and sharp, and that soft tissue detailing is visualized, and you can visualize the anterior region, fat pad region, in front of the knee joint right here. So here is the radiologist report. Under findings, it says no evidence of acute fracture or dislocation, moderate degenerative changes along the lateral aspect of the femorotibial joint compartment noted, similar to prior exam, mild degenerative changes of the medial femorotibial joint compartment, similar to prior exam, no significant joint effusion. Impression says moderate degenerative changes of the patellofemoral joint compartment and mild degenerative changes of the medial femorotibial joint compartment, similar to prior exam. And then here I have terms to identify, so although there wasn't an actual pathology noted in the report, I did write down degenerative changes, which is a progressive process that causes bone tissue to break down, soften, and become weaker over time. This process occurs when bones lose minerals, especially calcium. And then the most common degenerative bone disease is osteoporosis. And then other medical terms that were mentioned included acute fracture or dislocation. Fractures are breaks in the structure of bones that are caused by force, and dislocations are when a bone moves out of place from its original spot and connecting joint. And then we have joint effusion, which is fluid buildup around a joint, which causes a lot of swelling. To conclude this presentation, I'm going to go over what we learned. So we reviewed how to differentiate each position of the knee out of the 4 during a routine exam based on the position of the anatomy demonstrated. We reviewed how to determine the proper amount of part obliquity for both internal and external rotations of the knee based on superimposition of the tibia and fibula and based on superimposition of the femur and patella. And lastly, we reviewed how to identify over or under rotation of a lateral knee projection based on the superimposition of the posterior borders of those femoral condyles. And then here are all of my references listed.